I think almost all of you come from anesthesia. These are my disclaimer. So coming from anesthesia is sometimes hard to think that you are becoming surgeons. And very few of you, during my now long experience, having fellows and interacting with you, have accepted that, in fact, you are becoming surgeons by serendipity and not anymore anesthesiologists. And sometimes you are mixing up different techniques, and you should also pay attention that the evolution of surgical therapies is the real evolution of humankind. We learn to remove at the very beginning, and sometimes we're removing, people talking here, repairing, external or internally, fixation, reducting, sealing, restructuring. We learn to restructure through anastomosis, now endovascular endoscopic surgery, which are important specialties. The very important creation, not innovation, creation of the syringe in the late 19th century, who let us inject drugs in a precise site. Then we learned also to ablate the neural and vascular structures by means of physical instruments, the scalpel, then electricity in the early 20th century, radio frequency by mid-century. Some of us were attending the very beginning times of radio frequency in Boston in the 80s. Then also implemented radiosurgery and nuclear ablation with a gamma knife in the late 20th century. And we learned also to replace in the early 70s. Then electrical stimulation of neural structures from the early 70s. And finally, to regenerate. As yesterday, these two extraordinary and talented professors gave us extraordinary as well lectures. So you have to keep in mind this, because this is maybe this is the most important thing I have to say to you, because you are using different alternatives. You are using different tools. You are doing surgery. And sometimes it's difficult to specify, am I removing, am I ablating, am I replacing or stimulating? So I think it's important for you to keep it in mind. So interventional pain specialty is difficult because to work on just a discipline is like to speak just one language, as it reduces our reality. As long as you are moving from anesthesia to surgery or interventional pain, because interventional pain specialty is surgery, then you will little by little change in your mind. No matter if the head of your department allow you to think as a surgeon, because it is one of the real important deficits of the pain clinics, the hospitalary pain clinics all over the world. So we know also that interdisciplinary knowledge improves in a wave mode of concentration and dispersion. So sometimes in some years we put much knowledge inside a concept, and in some other years then this concentration disappears. As an example, it's important to remember that Maxwell in 1865 compiled magnetism, electricity, and optics in one discipline, the electromagnetism. Einstein in 1905 compiled mechanics, thermodynamics, and electromagnetism. And today, hopefully, quantum physics and gravitation will be unified. Why I say that? Because we have to be open-minded. We were defending opioid therapies for decades. From the first paper appeared in Pain, if I remember well, in 1984 by Arner in Sweden. We stated that some of the neuropathic pain problems could be relieved by the use of opioids. Of course, at that time we were introducing in the clinic the use of opioids as an important therapy, pharmacological therapy, for treating cancer pain syndromes, but just for malignant pain. What happened then? The guys from the United States, mainly the group of Caroline Foley, then Portnoy, started to promote studies arguing that the use of opioids could possibly have an important role in therapy. Now this is the situation. The situation is that last year an estimated 59,000 Americans, last year 2016, Americans died from a drug overdose, many linked to the misuse of prescription drugs. This is quite simply an epidemic. So, according to our colleague, Broder, that seldomly comes here to visit us, opioids have rightfully been the focus of many countries and US states' attention over the past several years. The move away from opioids as the primary treatment for chronic pain conditions should continue. Physicians should emphasize the diagnosis of an objective pain generator before initiation opioids. Alternative modalities must be tried first, including physical, occupational, psychological therapies, precision injections, and neuromodulation. The goal must be to utilize opioid-sparing treatments. Do you see outside many pharmacological companies supporting us? Why? Because we are surgeons, because we are promoting physical therapies. Physical, in some way physical, because we look for the to persuade also the others that body hurts. The body hurts. And the more specific we are, the better we'll do with our patients. Same is for radiofrequency. My time is going on, so you must understand that also modern societies threaten with isolation to those who express opponent opinions to the majority. Therefore, it is mandatory to vindicate individuals' self-determination in front of collective thinking, because the only possible self-determination is individual freedom. That happened when we started and founded with Professor Racz, Professor Erdine, and the late Priti Raj and David Neves, the World Institute of Pain in 1993. We were completely isolated from the other societies. And it's important to remark it, because you are starting with a career. And then you have to choose your opportunities in order to maintain your freedom and to look for the better, for the best therapies for patients. And this is our moral obligation. And we have to remind you that we are defending a philosophy, a way of thinking. We are not just technicians. We are not just experts in different technologies, but we are also philosophers. And that is the reason that we chose to be doctors.